Welcome back, ladies and gentlemen, to another episode of Med School Mondays with Provo. Today we're going to focus on, well, what happens when we have too little thyroid hormone, and that is referred to as hypothyroidism. So if you guys were with us last week, we talked about the synthesis, the regulation, as well as the effects of thyroid hormone. Now, if you missed that lecture, I highly suggest you go check it out because it's the foundation lecture for both hypothyroidism as well as hyperthyroidism. But a quick little review just so that this lecture makes sense as well. What do we have over here? We got the hypothalamus. The hypothalamus is releasing this hormone called the TRH, thyroid releasing hormone. That acts on the anterior pituitary gland. The anterior pituitary gland releases TSH, thyroid stimulating hormone, and the thyroid stimulating hormone works on the thyroid follicular cell, releasing T3 and T4. What I'm trying to illustrate over here is that T4, thyroxine, is made in large amounts compared to T3, triiodotyrosine. However, T3 is a biologically active form. So remember, the T4 needs to actually convert into T3 by that enzyme, which you guys remember is called 5'-deiodinase. Awesome, guys. Okay. So what happens when we don't have enough T4 or T3? We got a condition called hypothyroidism. So let's get right into it. Let's talk about the clinical features first. Intolerance. What do we mean by intolerance? We're saying the patient is intolerant to cold weather. So cold intolerance. That means when all of us are relaxed, wearing t-shirts and shorts, these people are usually bundled up in sweaters and scarves and hats. Weight. There's going to be a lot of weight gain with these patients. And why is that? Because the basal metabolic rate is actually decreased. Appetite is going to be decreased, activity level is going to be quite low, so the patient is going to present with weakness, lethargy, loss of energy. Bowel movements, again, think of a hypothyroidism patient as very slow patient, so slow bowel movements, meaning constipation. Reflexes are going to be delayed. Mood, the patient is going to present with a depressed mood, so you're going to do your clinical screening for depression. You're going to get the SIGI CAPS mnemonic, sadness, loss of interest, feelings of guilt, energy loss, concentration is decreased, attention span is decreased, psychomotor retardation. Patients also going to present with sleep issues, maybe sleeping too much or not enough, as well as perhaps sexual issues. Proximal muscle weakness. So when we talk about hyperthyroidism, these patients also have proximal muscle weakness. But in hypothyroid patients, what happens? The amount of CK is increased. Creatine kinase is increased. We call these patients hypothyroid myopathy. Myxedema, the patient is going to present with peri-orbital myxedema as well as facial myxedema. The skin is going to be very dry and cool. The hair is going to be very coarse and brittle. It's going to fall off easily. The heart rate is going to be slow, referred to as bradycardia. So cholesterol levels will be quite elevated, and that's because there's a low LDL receptor expression. It's also associated with euvolemic hyponatremia as well as carpal tunnel syndrome. Complications, you have to remember the severe complication that may happen is called myxedema coma. We're going to talk about that at the end of the lecture. And over here, we also got sexual issues. Now, what kind of sexual issues are we talking about? If you were with us back when we first talked about the prolactin regulation, we said that when there's too much thyroid releasing hormone, it actually stimulates prolactin levels. When prolactin levels are stimulated, it inhibits gonadotropin releasing hormone, leading to low FSH, follicle stimulating hormone, as well as low LH, luteinizing hormone. So if it's a female, she's going to present with a decreased libido. She's going to present with menstrual issues. If it's a man, again, decreased libido as well as impotence. So those are your sexual issues you would probably see in a hypothyroid patient. So how are we going to deal with this? Well, we want to measure the labs. We're measuring the amount of T3 and T4. That's obviously going to be very low. And we want to measure the levels of TSH. Now, depending on if it's a primary issue, a secondary issue, a tertiary issue, the TSH levels will range. So let's start off by looking at this quick little diagram again over here. If it's a primary issue, that means the pathology is at the level of the thyroid. So it's not releasing enough T4, T3. Well, what happens then? It sends a signal to both the hypothalamus as well as the anterior pituitary gland to increase its release of both TRH and TSH. So in a primary hypothyroidism, T3, T4 will be low, TSH will be elevated. If the issue is at the anterior pituitary gland, we say it's a secondary issue. If it's a secondary issue, that means for some reason, the anterior pituitary gland is not releasing enough TSH, meaning there's not enough T3, T4. So TSH levels will be suppressed, T3, T4 will be low as well. And of course, if it's a tertiary issue, that means something's happening even above. So the hypothalamus is not releasing the TRH, no TSH, and ultimately no T4, T3. So all three of those values will be decreased. Just to remind you guys again, LDL receptors, we know that the LDL receptors will be low. That's why this leads to the hypercholesterolemia right over here, hypercholesterol levels. Awesome, guys. So now we got the regulation, we got the clinical features, we got the labs. Let's talk about the causes of hypothyroidism. We want to start over here with Hashimoto thyroiditis. Hashimoto thyroiditis is the most common cause of hypothyroidism in a region where iodine is sufficient. It's an autoimmune disorder, so we have autoantibodies. These autoantibodies are referred to as antithyroid peroxidase, also known as antimicrosomal antibodies, and you got the antithyroglobulin antibodies. These patients have an increased risk for non-Hodgkin's lymphoma. A non-Hodgkin's lymphoma is of a B-cell origin. On histology, you see Hürthl cells. You also find lymphoid aggregates within the germinal centers. Clinical features, all the stuff we just discussed already. The physical exam, the thyroid gland is going to be a little bit enlarged, but it's not going to be painful, so non-tender. Treatment, how do you treat these patients? We treat it with the T4 analog. The T4 analog is referred to as levothyroxine. Adverse effects you want to know, it increases heart rate, the patient develops tremors, and it also talks about heat intolerance. So that means the opposite. When everyone is feeling cold, this patient is going to feel quite hot. Let's move along on this side over here. We got congenital hypothyroidism, also referred to as cretinism. So you got to think of a few other causes. We talk about some of the causes that cause this is maternal hypothyroidism. That means the mother is not getting enough, is not producing enough thyroid hormones. We got problems with the actual development of the thyroid gland. So there's thyroid agenesis, where the thyroid gland doesn't develop, and we got thyroid dysgenesis, where the thyroid gland develops but not properly. So thyroid dysgenesis is the most common cause in the States, where iodine is actually sufficient. And then of course we got iodine deficiencies. The clinical features, the 6 P's. First letter P stands for poor brain development. Second P is the pale face as well as the puffy face. The fourth one is a protuberant tongue, then you got a pot belly, and you also got a protruding umbilicus. So the 6 P's, do not forget that. Treatment, also thyroxine. However, this time it's very important that you start the treatment very, very early on. If you wait for treatment to be delayed, guess what? The brain's not going to mature properly, and that's going to lead to lots of complications for the baby in the future. The next one, another cause of hypothyroidism, is referred to as subacute granulomatous thyroiditis, also known as de Quervain's. De Quervain's rhymes with pain. So remember that. We'll talk about that in the clinical features in just one second. But remember that. This is associated with a flu-like illness. So that means usually it follows a patient who just had a viral infection. Early on in the state, the patient is actually in fact hyperthyroid. So we're going to see some of the opposite effects of too much thyroid hormone. But later on, it eventually leads to a hypothyroid condition. On physical exam, the patient is going to develop a jaw pain as well as a tender thyroid. On histology, like the name suggests, granulomatous, inflammation. On labs, you will see an increased ESR, erythrocyte sedimentation rate. Treatment is self-limiting, but of course, since there's a lot of pain involved with this, the jaw pain, the tender thyroid, you can also give aspirin. So let me come on this side. We'll talk about now bridal thyroiditis. What's going on with this? The pathology is that there's fibrous tissue which replaces normal thyroid gland. The fibrous tissue can now extend to different local structures. Those include the esophagus and the trachea. It actually mimics an anaplastic carcinoma. On physical exam, you find it's a fixed, hard, rock-like thyroid. It's actually non-tender, so we say it's a painless goiter. Complications, like we said, the fibrous tissue extends to the trachea as well as the esophagus. So if it extends to the esophagus, the patient is going to present with a dysphagia, having trouble swallowing food. If it's extending to the trachea, there's going to be some airway obstruction. Patients could present with a stridor. And also if it involves a recurrent laryngeal nerve, the patient is going to present with hoarseness of voice. Another interesting fact is, you want to keep this in mind for your boards, it's an immunoglobulin G4 related disease. So it affects many different organs. One organ it does affect is the pancreas, causing pancreatitis. Treatment, you want to treat with prednisolone as well as surgery. Other causes, of course, there's iodine deficiency. We talk about things that can always happen in the brain, right? And that's going to lead to both secondary causes as well as tertiary causes. So anything that's happening up in the hypothalamus at the anterior pituitary level, start to think about trauma, start to think about vascular causes, ischemic causes, infections, again, TB, syphilis, tumors, craniopharyngiomas, meningiomas, okay? Medications, important medications. 2 medications you want to remember. The first one is referred to as amiodarone. Amiodarone is used to treat ventricular fibrillations as well as ventricular tachycardias. But the side effects of amiodarone are quite important. There's a nice mnemonic. We always say with amiodarone, you want to check the TFTs, the PFTs, and the LFTs. TFTs are your thyroid function tests. PFTs are your pulmonary function tests, and LFTs are your liver function tests. So remember that nice mnemonic. It also causes the skin of the patient to change into like a blue smurf-like skin. So we say blue smurf-like skin. Another medication that we want to tell you about is lithium. We've already been aware of lithium when we talked about the Diabetes Insipidus lecture. So lithium has a nice mnemonic as well with its side effects. LMNOP. L stands for lithium. M stands for movement disorders. What are we saying? Tremors, basically. N, nephrogenic diabetes insipidus, like we talked about back in the day. O stands for hypothyroidism. And P, of course, with lithium, we know it causes pregnancy issues, so we avoid in pregnancy. Awesome, guys. And last week we talked about this over here, the wolff-chaikoff effect. Well, what happens in the wolff-chaikoff effect? We said when too much iodide is being transported into the thyroid follicular cell through the iodide transport or the iodide sodium cotransport, that actually in fact inhibits the organification step. If you inhibit the organification step, what happens? You're not producing enough T3 and T4, leading to hypothyroidism. Awesome, guys, awesome. And like promised, I wanted to draw your attention one more time to the complications. So with any of these diseases over here, any situation causing hypothyroidism, well, what happens? Long-standing untreated hypothyroidism can eventually lead to a myxedema coma. So what happens with myxedema coma? The patient presents with decreased level of consciousness, the patient presents with respiratory depression, and the patient presents with severe hypothermia. So what causes the myxedema coma? Think of any sort of precipitating factors that may have caused stress to the patient. We think of exposure to cold. We think of exposure to medications such as narcotics. There's if a patient just had a heart attack, if the patient has congestive heart failure, if the patient just got recently some sort of infection. So any sort of precipitating event can lead to a myxedema coma. Now this is very serious. It's treated like a medical emergency. Take the patient, admit them to the ICU, start them on IV levothyroxine right away, and you also want to start the patient on hydrocortisone. That's it, guys. That's it. That was hypothyroidism for you guys in a nutshell. Again, if you guys missed the last week's lecture, I highly suggest you go check it out. The link will pop up in a few seconds, so you don't even have to do that much work. Next week, what are we going to do? We're going to talk about the opposite. We're going to talk about too much thyroid hormone, referred to as hyperthyroidism. I want to thank you guys again for joining me today. In the meantime, give the video a thumbs up, share the video with your friends, comment on the sections below, and definitely subscribe to the channel. And we'll see you guys next week on Med School Mondays with Promo.